Chairman, ladies and gentlemen. Radiotherapy has a curative role in the treatment of women with early breast cancer following surgery, preventing on average about 20 local relapses in the preserved breast, for example, per 100 women irradiated, and preventing one breast cancer death for every 4 local relapses prevented. And the study that I'll show you provides convincing evidence that compared to a standard radiotherapy regimen, which delivers a total radiotherapy dose of 50 gray in 25 fractions over 5 weeks, a lower total dose delivered in fewer visits to hospital over a shorter time can be gentler on the normal tissues and non-inferior in terms of local tumor control. The START trials are large studies. They include almost 4,500 women. And there are 2 studies, one explanatory in design and one pragmatic. And both take 50 gray and 25 fractions over 5 weeks as the control group. In the upper study, that control group is compared against 2 test dose levels of a 13 fraction regimen, which is given over 5 weeks to control for treatment time. And that allows an unconfounded direct estimate of the sensitivity of both normal tissues and the breast cancer to the size of the fractions. In the lower panel, it shows the design of a pragmatic trial comparing the 50 gray and 25 fractions against a 15 fraction regimen given over 3 weeks, so a shorter overall treatment time, 2 variables altered, a regimen that has been used in the UK for several years but never formally tested. The primary endpoints of both studies is local regional relapse within an irradiated volume of tissue, and secondary endpoints include, as well as physician assessments, photographic assessments, and importantly, patient self-assessments, and those have already been published. Recruitment involved 35, or approximately 2/3 of all United Kingdom radiotherapy centres between 1999 and 2002, and follow-up is now mature at just under 10 years. The baseline characteristics of these 2 trials, A and B, are shown here. They show the prognostic and demographic features of a group of women that are typical to those presenting in the UK more than a decade ago. They are predominantly postmenopausal women who are referred for radiotherapy after breast conservation surgery for stage 1 or stage 2 disease. At least half of them have a boosted dose of radiotherapy to the vicinity of the primary tumour following their whole breast radiotherapy. And between 1/4 and 1/3 have adjuvant chemotherapy, and a large majority have adjuvant endocrine therapy. And if you scan those 2 features, you'll notice that the prognostic features of the women in trial B are slightly more favourable than those in trial A. In terms of the trial A results, on the left is a Kaplan-Meier plot over 10 years of follow-up for moderate to marked clinician-scored adverse effects at annual assessments, including breast shrinkage, hardness, edema, and telangiectasia. And the first thing to notice is that events continue to accumulate over a 10-year period. Secondly, that you can easily discriminate the 2 levels, the test dose levels of 13 fractions, 39 gray and 41.6, those differences are clearly statistically significant. And thirdly, that the test dose regimen that most closely resembles the control group is the 41.6 gray regimen in 13 fractions. And then the question is, which of those 2 test dose regimens resembles the control in terms of local tumor control? And the cumulative probability plot on the right-hand side shows at a glance that, well, yes, it's the same schedule, 41.6 gray in 13 fractions, which most closely resembles the control group. And this shows that the breast cancer and the normal tissues are responding in the same way to these lower total dose, and that this regimen, for example, in principle would be both safe and effective. But a 13 fraction regimen over 5 weeks is not convenient for patients. And that's why the pragmatic trial B is of greater interest in practice. On the left, the Kaplan-Meier plot showing the percentage of patients remaining free of the same adverse events over 10 years is shown. And again, you can see at a glance that the test group is developing fewer adverse effects. A hazard ratio of 0.77 means in practice that on average about 8 fewer women per 100 treated are developing significant adverse effects after radiotherapy. The question is whether that treatment is also gentler on the cancer. But when you look on the right, you'll see there's no evidence of that. In a non-inferiority trial, there's no suggestion that the test schedule is inferior to the control group. And you will notice that the confidence intervals attached to the hazard ratio at the foot of the slide make it very unlikely indeed that this schedule could be more than 1% inferior. And in fact, it may be 2.5% superior. So that in conclusion, we can say that breast cancer and the dose-limiting normal tissues respond similarly to fraction size, and that there's no advantage in any sense in continuing with the traditional practice of 2 grade fractions over 5 to 6.5 weeks. That the 15 fraction regimen over just 3 weeks is gentler on the normal tissues and non-inferior in terms of local regional control of the cancer at 10 years. And that this schedule has been standard of care in the United Kingdom since 2009 for all patients with invasive breast cancer referred for post-operative radiotherapy in accordance with the guidance of our National Institute for Clinical Excellence. Thank you.
Thank you.